Yes, glenzocimab is a platelet GP6 receptor antagonist. So theoretically, at least, it blocks platelet adhesion, but doesn't promote bleeding. And there was an initial study that was carried out in Europe, which was a dose finding study. And in addition to identifying an optimal dose, the company thinks, it showed that there was no increased bleeding in 100 patients, 50 patients or so that were dosed with glenzocimab at the appropriate dose, and 50 controls. There was no increased bleeding. As a matter of fact, surprisingly, a little bit, there was reduced bleeding. Considerably, there was no bleeding in the glenzocimab group, even though these were relatively serious strokes. So, just to amplify a little bit, when they found that there was lower mortality and less bleeding in that early pilot study, we remember that platelets have a pro-inflammatory effect also in reperfused brain. So in addition to blocking platelet adhesion, it's possible that the drug is having an anti-inflammatory effect in the sense of reducing membrane damage and hence reduced bleeding after the stroke. Based on those considerations, based on the pilot study, which was a small number of patients, we jumped to a phase 2b, phase 3 study, which was the ACTISAVE study. And because the thought is that the drug does reduce platelet adhesion, the thought was that it would amplify the effect of TPA or TNK and also thrombectomy by preventing clot reoccurrence. So the study was designed on top of either thrombolysis with either TNK or TPA, with or without thrombectomy. The idea was to have at least a third of the patients have thrombectomy because, at least theoretically, because of the things I mentioned earlier, we thought the drug might be most effective in large strokes where there's a risk of bleeding. The study started in Europe a few years ago and really was started in 2021. And most of the patients have been enrolled in Europe, a handful in the United States, because the United States centers just came on board this year, and has been enrolling on schedule and was approved by the European authorities with several different endpoints, including dichotomized Rankin scores and shift analyses. And has been there have been no signals of increased risk or anything to stop the study. The FDA, however, did not suggested quite strongly that we needed to pick a single endpoint, dichotomized Rankin score endpoint, and did not accept the notion of co-primary endpoints that the study was initially. So, and of course, all of this happened blinded to the data. We have no idea what and the company has no idea what the data is showing. So if you use a dichotomized endpoint, then your sample size is going to be much smaller. And so you decided to use a sample size of 400 or so patients would be enough to see a difference in outcome in severe strokes or non-severe strokes. And so the study has been crafted, not recrafted, but the decision was to stop the study at 400 patients and consider it a phase 2 trial. The data that I presented at the World Stroke Conference was simply the group safety data in the first 100 patients, because those patients had all been followed up. The DSMB has evaluated them. I don't know anything about which group is which, but we could see the overall bleeding rate was extremely low, and the demographics were such exactly what we wanted. These were relatively severe strokes. About a third of the patients had gone on to have thrombectomy, and so that's essentially what we presented. I can tell you that the study will end enrollment. We'll have over 400 patients at the end of this month in October. So we should have the data at the second quarter of 2024. So it will be the next big, 400 patients is a lot of patients. It's not a phase 3 trial, but it will inform us whether Glenzocimab is having an effect on bad outcomes and reducing bleeding like we propose. And if not, is there any other signal of efficacy?